So hello, good morning, good afternoon and good evening to all our speakers, chairs and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from Spain, Professor Jesus Martin Fernandez. Dr. Jesus is a neurosurgeon and a cognitive neuroscientist. He serves as the Chief of Neurosurgery and Head of Awake Cognitive Mapping Multimodal Department, UNCOG, at the University Hospital La Candelaria, Tenerife, Spain. He is widely recognized as one of the leading international figures in awake brain surgery. His work includes the development of first AI-based intraoperative assessment designed to preserve emotion recognition during glioma surgery, as well as description of technical variant of three-step awake cognitive mapping, bringing neurosurgery into close dialogue with computational neurosciences and complex dynamical system theories. He is currently the president-elect of the World Society of Awake Brain Mapping. His main research focus lies in the advancement of cognitive mapping and preservation of higher-order cognitive functions in the context of complexity science and in the development of computational models of whole brain perturbations induced by direct electrical stimulation. We are extremely honored to have him today with us as a speaker for our webinars, and today he'll be talking about three-step awake cognitive mapping beyond the fallacy of cortico-centrism. The speaker for the second session of today is our honorable guest from China, Professor Zhao Rui. Professor Rui is a chief physician and director of epilepsy surgery program in the Department of Neurosurgery at the Shanghai Children's Hospital School of Medicine, Shanghai Jiatong University, China. He specializes in pediatric neurosurgical disorders with extensive experience in refractory epilepsy, brain tumors, and congenital malformations of the nervous system. He is a member of the SEEG and Brain Localization Professional Committee, China Association Against Epilepsy. He is a member of Neuromodulation of Professional Committee, CAAE, and member of the Professional Committee of Epilepsy Surgery and Preoperative Evaluation. He is a noted author who has published several papers in leading journals like Nature Communications, Neurology and Neurosurgery. He has also won several awards and honors for his outstanding service to neurosurgery. We are extremely honored and grateful to him for accepting our invitation to be a speaker at our webinars, and today he will be talking about robotic guided SEEG placement in epilepsy surgery. The chair for the first session of today is our very honorable faculty from Italy, Professor Francesco Sala. Professor Sala is a professor and chair of neurosurgery at the University of Verona in Italy. His main clinical and research interests are pediatric neurosurgery and intraoperative neurophysiology. Professor Sala is one of the co-founders of the International Society of Intraoperative Neurophysiology, where he served as a secretary till 2011, chairman of education till 2013, and president till 2015. He currently serves as a president of the EANS, and he is particularly committed to the training of young neurosurgeons and development of intraoperative neurophysiology in global neurosurgical community. He also taught training courses at the European Association Neurosurgical Society, and is also executive board member of the same. He was appointed as the first chair of Neuromonitoring Committee of the World Federation of Neurosurgical Societies, and we are extremely honored and grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is our esteemed faculty from India, Professor George Villanilum. Prof. Villanilum is a professor and head of Department of Neurosurgery at the Sri Chitra Tirunal Institute of Medical Sciences and Technology, Trivandrum, Kerala, India. He is an expert in the field of epilepsy surgery who has authored and co-authored several articles in his specialty in several internationally reputed journals. He is also an invited faculty to various conferences and workshops around the world. We are extremely grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Libun Singh from Malaysia is my co-host for today. With that introduction, I would like to hand over this podium to our first chair, Professor Francesco Sala.
Thank you, Raja. Thank you, Dr. Krishna Kuti. Thanks to the ACNS for the invitation. I'm truly delighted to be here. And I'm very much looking forward to Dr. Martin Fernandez's lecture. This has to do, of course, with neuro-oncology and the way we approach surgery for brain gliomas. Nowadays, we have experience of the last 20-25 years on evolution of the, let's say, the dilemma of maximizing resection of this tumor while minimizing morbidity. Obviously, all the pre-surgical functional planning as well as intraoperative neurophysiology have played a major role into this. Of course, we have also witnessed over the last 3 decades blossom again of awake surgery, which of course is not new because Wilder Penfield was doing this more than a century ago. But certainly over the last 2-3 decades, particularly thanks to the work also of colleagues such as Hugh Dufault, Mitch Berger, Lorenzo Bello, many others, they have really pushed the frontiers of surgery, particularly for the low-grade gliomas. And we have progressively abandoned the concept of localizationism in brain surgery. We all grew up with the idea that there are eloquent cortical areas here and there. But now, of course, we know that the brain works in a much more sophisticated way. So we abandoned the concept of eloquent cortical areas towards the concept of connectomics and functional networks, both for motor, language system, and all the other system. And we are still limited, at least from the intraoperative neurophysiological monitoring standpoint, to monitor all functions, particularly the higher order functions. Of course, we can do that during awake surgery, but awake surgery is not suitable for all patients. Just think about children, for example. So we need to move the field forward, and certainly Dr. Martin Fernandez's work has been very much into this direction, is now pushing the borders even further with a new concept. I welcome him, and I'm looking forward to his lecture. Thank you.
Thank you so much, Professor. It's really my pleasure to be here with you, and thank you so much to all the ACNS. But really, it's a pleasure to be here with you. I know perfectly your work. I have studied your work, and we are in the same line, trying to pursue the challenges that the brain put to us. I will talk about exactly what Professor Francesco Sara was talking about. We are now trying to go beyond the eloquent areas and trying to create a more sophisticated framework to understand concretely the higher order functions, because it's really difficult for us to understand during the pre-surgical mapping or the pre-surgical planification, and even intraoperatively. So we are trying to go beyond the cortico-centrism that has been guiding us. So I will be, of course, respectful, but also provocative in a good way, trying to go further. So I'm from here. This is the Canary Island. We are really next to Africa, and also to Europe, and concretely Spain here. So we are a little bit in the middle, in the boundaries. This is our site from this space. You can see here we are really more next to Africa than to Spain. And this is our hospital. We are so lucky. We have a department only dedicated to awake cognitive mapping, and trying to develop this from the micro scale to the cognitive and behavioral scale with neuroengineers, neuropsychologists, and awake cognitive mapping. And all our work is in these lines. We are also studying the higher order functions, concretely social cognition and emotions and behavior, with some powerful agencies like the European Space Agency. And we are trying to in some way, to understand this higher order functions better, just to go into the OR and have a new framework and understanding better. Probably the biggest problem of us as a neurosurgeons is that we have been trained to understand the brain as it looks and not as it works, because it's obviously difficult. And when you have the brain when you are doing a dissection ex vivo, you can see the fibers, you can see the cortical surface, but finally we don't know exactly how it works. So we are now in these last decades with Bell, of course, Dufault, or so on. We are trying to know exactly how it's working. So we have been until now looking at the brain probably as a 3D system. But from computational neuroscience, we have other framework. So I like this example is from David Cracker, where he's the director of the Santa Fe Institute, which is based on complexity science. And he put an example of the brain of the wall. If you can see the wall as a wall A, where the wall A is classically you see a lesion in the prefrontal cortex, and you say, okay, this patient will have a problem in social cognition. But this way of looking at the brain is closed, it's symmetry dominated and predictable. But finally, we know that this is not exactly like that, because otherwise we could not remove the prefrontal cortex in patients with, for example, low-grade gliomas. So the other vision is that the worldview that David talked about is better fitted to understand higher order cognition. So higher order cognition compared to the motor functions is it's an emergent process, and it's depending on delocalized systems or networks. So it's really different. The problem is how to get fitted these two visions of the higher order functions and the lower level functions. So we are trying to go through the computational neuroscience, trying to understand some things of this. So in the world A, we have classically the case of Broca. Finally, when our colleagues from Bordeaux, they studied the brain of this patient, we saw that really the damage was more from the subcortical tracts and the cortical surface, but Phoenix Gage didn't perform a dissection to tell us that really the problem was more than the pars opercularis and triangularis. Right? Talking about computational neurosciences, we are more in this way. You can see here the metastable brain waves and how the brain, I will talk about this, how the brain is changing across 4 seconds, 5 seconds, changing the exactly how it is connected and why this is important for the cognition. As I talked about previously, this is a resection from Professor before, and if we were based on cortico-centrism, this was not possible to resect both frontal lobes without any deficit in neuropsychological terms. So when I saw this, of course, to say, okay, but what about Phoenix Gage? What about the frontal lobe? What about all the connections? And of course, I know that neuroplasticity is a perform a great job in low-grade glioma. It's not enough probably to explain this kind of resection without deficits. So we really try to go farther than our frontal lobectomy based on the functional boundaries. So we propose that the cortico-centrism could be a fallacy because of, first of all, it has some kind of axonal myopia. So we don't have so much books where we can understand what happens if a patient has an affection of the eye in the right side, for example. We don't know exactly what's happening and if the patient is going to have a problem in theory of mind or not. Secondly, it's an observational model based. So it's like this is lesion, so you have this deficit, or you have this other region lesion and you have this deficit. It seems not to be really exactly like that. There is not a mathematical model possible for us as a computational neuroscientists to validate it or not. So we are a little bit blinded when we go for the cognitive mapping. This is the problem. We keep on treating the neuroplasticity as a black box. Like, this should be, the low grade should have translated the functions further, because of that we can perform a maximal self-resection. But why? So how it's possible? What's happening below that? And it can't explain the interindividual variability when you do the cognitive mapping. It's absolutely different from one patient to another. So it makes it really complex cognitive mapping for us. And also it can explain two phenomena that we see in the mapping, in cognitive mapping, which is degeneracy, which means that you can have the same problem. For example, no no possibility to recognize an emotion in different parts of the brain, or not being able to name an object, or the pluripotentiality, which means that you can have the same point positive for different kind of functions. So we also have been traveling from the cortico-centrism to this kind of non-locality of higher order functions from the complexity point of view. And so we have been also trying to develop new tests for cognitive mapping, and concretely for social cognition mapping, because we need to adapt to the new things that connectomics and cognitive sciences is developing. So we always put this example to explain this how the networks get organized to explain or to substitute the higher order functions. So we put this example of the birds that are able to, from being randomly organized to perfectly being synchronized, to get this kind of state in order to be really away from the predators. So this is just an example that is it is to understand that what is subserving the higher order function, and why it's different from, for example, language. So we know that we see the brain as a 3D system, but finally we know that it is dominated by non-linear interaction, which means that each single time I simulate a single area, the same area, we will have different responses through the brain and through the cortex and all the structure. The brain seems to be also a self-organized system from the microscale to the microscale to the macroscale. And then we have a new concept like as the brain is operated in a criticality, which is a perfect point between the order and chaos. In this point, it's not like we have the default mode network activated or the silence network. It's more like it's changing from one state to another. And when we do the cognitive mapping, we don't know in which state we are and what is exactly happening. So this seems to be the new points to be involved in and to go really deeper. So we propose this paradox of non-locality because, for example, you can reconstruct the default mode network before the surgery, but finally, only the points where you simulate when the patient is performing social cognition task, you will have the 1 centimeter point that is really critical and which will be the boundary of your resection. So there is some kind of paradox of non-locality because the function is not there. The function depends on the several points of this network, including the default mode network, but the function is not there. It's simply a point with a higher hierarchy. So we propose this and we publish this trying to go further compared to the cortico-centrism. So the point began with you have the isolated brain regions. We can see in the fMRI with during task which regions are more activated or not. But when we add the spatial correlation, we began to have the large-scale networks when we know perfectly at this point in which functions they are involved. But if we put and we add the temporal correlation, which is the dynamics of this spatial correlation, and we add the second point which is the individuality. So, how different is it between patients? We have the brain states. So we are now talking about brain states and not about networks, because not all the time you will predict which network is activated. So when we analyze in this way the brain of our patients, we see that normally you have some kind of pattern of activation, which is predominantly the state 1, and then it's changing between the different patterns of activation. It's like the brain for the higher order functions need to be changing from one state to another, like in attractors. to have this property of higher order functions. I'm not going to talk about the mathematics of this, but we have this state, so like a network, but not the classic networks that we have studied before. This is, for example, one of our patients. We know that depending on which state is being studied, we have, for example, the state one, which you can see here, this network, which is not exactly a classical network. You have mixed, ventromedial prefrontal cortex, but also temporal lobe, but also occipital lobe. So you have 18 seconds, and then the stage 2 will be 3 seconds, and so it's really changing, and we begin to understand how complex is really the basics of cognition. So, we are trying to create this model from computational neuroscience to remapping, and these are our, all these people that has inspired us, from Broca to Dufault, and in computational science, Walter Friedman Jr. and Carl Frisson. So we are trying from the new engineering point of view to trying to describe mathematically why, when I put the simulator on a single region of the brain during a task, the patient fail, and I know that this is a critical point. So we are trying to develop this. We are in the process of doing this complex task that is appropriate already. And so we have proposed that only for cognitive mapping, only that points where the stimulation of a low frequency stimulation produces enough changes in the brain state transition will be the critical function where I should stop my resection, both cortically and subcortically. So based on this kind of uncertainty that it's of course it's like the core of the cognition is the uncertainty of where it's going to be the critical point, knowing that it's not where the function lives, but it's critical for the function. So we try to be step by step going to a more online and individualized surgery for the patient. So we published a 3-step away cognitive multimodal mapping. So the point basically is what happens when you stimulate a non-critical region for some kind of cognitive function. So the brain is going from one state to another without a problem, and nothing happens in the mesoscopic scale. But when you have a critical point, it seems that when you put the simulator, the brain cannot change from one state to another. This causes an impairment in the function, for example, an inability for mentalizing, or just the opposite. You have a mistake during the task. It's because it's not the normal transition between the brain states. So this is our hypothesis. Of course, it needs to be validated, but I think we need to, as people told me 1 year and a half ago in Brazil, we need to go further, and it's not enough to do to be doing the same that it has been doing the last decade. So trying to go to the neurosurgical field, what I mean is emotions are not mappable. So you can't map literally complex functions. You only, as a neurosurgeon, can localize some critical areas or higher networks. So it's really a paradox for us, because when you simulate or you localize the M1 for the face or the arm, when you stimulate, you see clearly a dystonia or an arrest of the flex extension movement. And you say, okay, here it is. When you map the critical function, a critical site for tension, maybe when you simulate again, probably the brain is in another state and you don't have the same response. effectively, the cognitive mapping is not a circus, and we really don't understand exactly how it functions, but we are trying to do it. But normally, in the last decade, when you read some papers that have been written before, you can read some things like if you perform a cognitive mapping, you will not be able to remove all the tumor because there will be a function, or the other point, which is the patient will be compensated after the resection, which is not really true, because when you analyze the patient, you can see that finally the patient has some kind of deficit in attention, in social cognition, in behavior, in personality. So we say that good qualities of life is not the patient is doing well or the patient is thumbs up and so on. So we are trying to go with neuropsychology to the behavior, to the personality, because we know that everything is not perfect after every section. And so finally, it's not true that the higher order functions are recovered by itself. So in the previous series, from 30 to 70% of patients have social cognition disorders. And this is why we have been focused in concretely in this function more than even than others. And talking about social cognition, which is the core of our work, we know that you have so different processes. For this reason, we prefer not to talk about emotions. We prefer to talk about social cognition, where you have the social cue perception. It's just recognizing the emotion based on the face of the person you are seeing. Even for the voice, you need to understand the prosody independently of the semantics. And then you need to understand the second order beliefs is what is this person trying to tell me without telling me? For that, we use a hinting test. Then we have the mentalizing, which is trying to understand the state of the mind of the other person. And this we have also more complex tests, which is like a multimodal integration of all of this. And you ask the patient before the surgery. The mask tests allow you to understand how the patient can be, how the patient is performing during the job or at home with the family, and how it's really understanding all the cues, voice, face, context, and so on. Of course, the problem is we can't measure all of this during the surgery because we have 1 hour and a half. So we need to create some kind of tests to try to preserve all of this, or at least the best as we can, but with one simple test validated independently of our population. This is normally how the neuropsychology works. So we published this test in Neurosurgical. This is based on AI. We tracked performing emotions to professional actors, and we put simply 2 avatars performing several emotions, complex emotions, and we validated it in healthy people and also in schizophrenia and autism spectrum disorder. And after that, we began to validate it during the surgery, and we have performed it in different countries, trying to be more accessible to low and middle income countries. So the stimulus is normally, as you know, 4 seconds. So you put the avatar, performing the emotion during the simulation. So we have been comparing what happened with the sleep group, what happened with the Mind the Eyes test, and then our test. Until now, we have a size of 74 patients. And you can see here is the different components of social cognition. This is the quality of life related to sexual activity, the multimodal social cognition, more real life-like. The second order beliefs, recognizing emotions by face, by voice, mentalizing, and basic emotions. So we see that in the asleep group really is worse compared to the reading the eyes, and even is better with the emotions test, probably because it's more dynamic, more realistic, and it recruits at some point executive functions. And when we compare the tumor resection opposite to what we have read before and what we expect, the resection is bigger when you perform the mind the eye test while the patient is awake, and a little bit bigger in emotions test. But it's really bigger than asleep patients. So I think we need to try to validate this in more and more case studies, of course. But another point which is important for social cognition is what about returning to work? So we compare previously to our department in our hospital what happened during in the group of asleep patients. So we have really a severe problem in returning to work, as you can see. It's really less than the 20-30% of the patients. You can see the comparison with the read-mind the eyes test, which is really bigger than the 70%. And until now, in our case series, we have a close to 100% of patients recovering to and being able to go to work after the surgery. We have tried to perform this in different countries that we have been invited to perform a low cognitive mapping and spread the philosophy that I learned in Montpellier with Professor Dufault. I have my own team with neuroanesthesiologists and a team of neuropsychologists to really prepare this. And we have been altruistically in all these countries. These were the first results with 90 patients. The point really is, of course, we will have the same complications as other groups. But finally, we perform the cognitive mapping in this way, but we still have a 9% of patients with a supratotal or gross total resection. And the return to work is approximately 82%, considering all the countries we have been operating on. And so it's not, it's not, I have no a new navigator, I have no enough things to perform the surgery. We really think that you just need a good team, a simulator to perform the mapping, and really being involved in cognition to have these results. So you can do independently of your country. Of course, it's better to have a brain lab neuronavigator, but it's you don't need it to try to go beyond that. So this little variation of the mapping is the three-step aware cognitive mapping. Is based on the first step, which is a cortical stage. So depending on the large-scale networks, and not the, for example, I'm not thinking about the middle frontal gyrus or the superior frontal gyrus to perform our mapping. We prepare the mapping with a neuropsychologist based on the large-scale network. So it's like, if I have a tumor in the temporal parietal junction, I will be thinking about the full mode network and the ventral attentional network and the dorsal attentional network that will be really even more critical than other functions that normally we map. After that, we performed the resection stage where we took this from default, the non-serial constant multitasking. So depending on the circuits that is underlying the tumor and close to the tumor, we perform different tasks changing in a non-serial order to see in an indirect way how the brain is trying to recover from the damage that we produce resecting the tumor. And finally, we go to the connectome stop point, which is a critical point of the fibers, the IFOF, the weight fascicle, the SLF complex, and whatever, because as it has been published by Mandanet, Vet, or Dufault, 1 millimeter of a cut of deep white matter tracts can produce long-lasting deficits because of large-scale disconnection because as you know, in the well-modeled tracts, a single millimeter can really be involved in different cortical structures. So I will put some examples and I will finish. Some classical cases. I think it's important to share more or less why cognitive mapping is important. There is a female, 66 years old. It's derived from the neurology as non-deficits. This is all usual. The patient had a seizure, and when we perform all the cognitive assessment, we can see that the patient already has some problems, for example, in visual spatial function, or in this case, in social cognition functioning at different levels. So the patient is not okay. Could be almost okay, but the patient is not okay until you perform all the single variables that includes higher order function. So based on specifically this profile of cognition, we prepare the mapping based on the higher order networks. In this case, that you can see the inferior parietal lobe. So we know that probably beyond the sensory motor functioning and network, of course, we have the ventral attentional network, dorsal one, and the default mode network, and then we have the tracts, and we prepare this kind of planifications with our team of neuropsychology to what kind of impairments we expect to have, depending on where I'm going through in the depth. So if I'm more anterior in the cavity, I will be more close to the SLF3, so I will have a dysarthria, for example, or neglect. Or if I go more posteriorly and profound, I will have the ITHOF with emotion recognition disorders and so on. So this is totally right lateralized. You can see here the sensory cortex, here in speech arrest in the ventral premotor cortex. Then the temporal parietal transition with critical point for semantic cognition, social cognition, neglect, and again semantic cognition. And then between the letters is the tumor. So we perform the tumor, and you can see in the depth the different points that we localized through the cognitive mapping. So in the classical, it was emotion recognition problems. SLF3 was anatria. The SLF2 was neglect during the bisection line test. We have then with the monopolar, we localized in 8 milliamperes, we localized the corticospinal tract, and then the IFO for semantic problems. And doing this, we could perform a gross total resection. So the point is, when you see the patient exactly after the surgery, and you perform, for example, the clock test, you can see really, you can understand really how cognition works, because after the surgery, the patient, because of you were working where the spatial visual spatial functioning is, you see a neglect of the patient, of course. It's not because you have not done the work, it's because you have been resecting the ventral and the dorsal attentional network. But if you preserve, in this case, probably the SLF2, which connects the dorsal and the ventral attentional network, you know that after 15 days, you will have the patient recover. This is the point. So normally, as you know, our patients really get worse during the surgery. After the surgery, sorry, you will have a decline because you have resected probably non-critical brain, but you have resected finally the brain. This is other cases, so classical cases from the lobe with invasion of the cingulum and corpus callosum. It was then sent to us because of as categorized as non-operable, which is you can think it or not. But we performed all the neuropsychological evaluation. The patient has really all the functions, all single functions intact. It was finally an oligodendroglioma, so we performed the surgery based on the same principles I have talked to you about. So we reconstruct depending on the large-scale networks like ventral attentional network, the limbic network, the frontoparietal network, and based on that, we prepare the mapping. And then, of course, again, the connectome subpoint. The problem that we have now is of course, we can have a good reconstruction, but which point exactly of the IFOF in the ventral or dorsal part will be the stop point? Which one? Because of course we have the fibers invaded by the tumor, but which point is exactly the critical one? So without the patient that's awake and performing the, the correct task, it will be impossible. So we have the same, like right hemisphere, lateralized, ventral premotor cortex, and negative motor area, different points for semantic cognition, social cognition, M1 of arm and hand, and all the region of the tumor with no critical points for higher order functions. Of course, the prefrontal cortex is doing the job part, probably because of the neuroplasticity, we are able, of course, to resect the tumor, and then profoundly, we need to localize all the single points, like multitasking problems for the SLF2 in the posterior part of in the transition between frontal and parietal parts. Then in the dorsal IFOF, getting the dorsal lateral frontal cortex, or the arcuate fascicle really close to the pars peripillaris. Then the head of the caudate with problems of classical frontoparietal loop, where the patient is not able to change from one task to another. And then at 8 milliamperes again, the corticospinal cut with monopolar. It was in this case for the corticospinal tract. And you can see, of course, then the MRI. Besides, it was a resection. The point is, why we could remove the cingulum, which is critical for the salience network and for social cognition and the corpus callosum. It's probably because of the neuroplasticity, and because probably this has a change and travel from one network to another. But if you don't map the cingulum and you see that the patient is able to, even independently of the simulation, the patient is able to recognize emotions and doing the WIT test and some other tests, it's impossible to be sure that you can reset the cingulum without causing a long-lasting deficit for all the rest of his life. So what I say normally in the congresses about the weight mapping, talking about cognition, is that we need to put numerically all the graphics. So in this point, we don't know exactly how this works. We need to see that this really worthwhile, and we really see how the patient has a declining, and then recover all the functions from attention to the personality, sexuality, memory, spatial cognition, and so on. This is part of my team. This is Natalia, my neuropsychologist. Jaime, my first, my helper. He was my boss during my residency. We try always to have the same team. He's Raul, the neurophysiologist, and this is the patient I showed you. I will finish with this case. This is similar to the other case. Maybe it's not so big, but we have this problem. Normally, we are receiving now patients after an a sleep resection. Where was not complete resection. And the point is why? I think that if you perform this kind of resections during in asleep conditions, as I told you, it's impossible to be able if you can resect the cingulum or not. And I think this is my opinion. This can cause a non-sufficient resection, and you can't perform a maximal sleep resection. So then you can do. Probably because again of the neuroplasticity, but you need to check it out. You need to check it out why you need to stop and don't resect the limbic network, but you can resect the rest of the tumor. So this is again the same way. There's the connectum subpoint, the anterior fascicle, ventral and dorsal IFOF, SLF2, and the cingulum in the part that we really have problems. So I won't put you more cases, but in the same way you can perform this kind of cases in Brazil, giant tumors in Poland, and whatever. So we have been with several teams and good colleagues that we have been meeting all over the world, and this, I think, part of our experiences. Thank you of our colleagues that really really were interested in understanding and studying and learning with us the cognitive mapping. Peru, Tenerife, Colombia, Brazil, Chile, Polonia. This was an inauguration of our department with, the Professor Borba and other colleagues from different parts of the world where we have been. And just some quotes I really like is, at least at my age, I prefer not to teach. I prefer to share with young people really my questions and really to tell them that I am not sure about some things of awake cognitive mapping because we're really searching for it. The other point is to encourage your students to question, my work, the work of Professor Sala, the work of Professor Bello, with respect, but try to encourage them to make questions and don't to take the assumptions. Because finally, my papers will be wrong in some years. So I prefer that. I think this is, of course, this is so personal and it's really special procedure, the awake cognitive mapping. But finally, the most important point is I recommend you not to forget your family and to enjoy with your parents, with your dog or whatever, because finally there is something more than neurosurgery, which is take care of your family. I encourage you to try to see a light on the other side and try to look for it. And finally, I need to. Sorry, the date is wrong, but this is recently we established the World Society for Awake Brain Mapping, where we have, of course, some of these faces. It's Lorenzo Bello, Hugh Tiffo, David Subsidich, Dr. Q, and so on. And we will have the first World Congress of the World Society from the 28th to 30th of January in Tenerife. I really recommend you. Soon it will be available to perform to really be an attendee of this congress. We really invite you to meet Canary Island and to meet Tenerife. So we really expect you to be there. Some more information will be soon available for you. And finally, thank you so much for the invitation. And we are here to share with you whatever you want. And always to keep on performing questions to ourselves and to take care of our patients.
Thank you, Jesus. Thank you, Dr. Martin Fernandez. Great talk, really fascinating. I have a couple of questions. One is a very practical one. It's not entirely clear to me how your procedure is different from what, Hugh Dufo is doing or Lorenzo Bello do in terms of the intraoperative cognitive mapping. So what would you highlight as the main different step or main advancement as compared to what we have been doing in the recent past? From a truly practical standpoint. So when you do the surgery, what you do different now has.
One of the main points of this was like putting in a single sentence what are we doing exactly. So the first point is just categorizing it like, okay, we will have 3 steps and we try to develop all over the world to be practically developed whatever, because it's, I think in the literature, it's not clear yet, even in our case, how to perform this, which are the stages, and what to do in each case. Other point which is really important, and I think it's different, is we don't, for example, social cognition and attention, executive functions, we don't perform only in the right hemisphere. We really perform in the bilaterally because of the large scale networks. Because we have been seeing in our patients that independently of the right or for example, the left, we see in the insula or the dorsolateral prefrontal cortex or the temporal parietal junction, the left side, really high prevalence of social cognition. So we really try to be less and less lateralized in terms of mapping. So of course the lexical access is critical for the left side, and we know that. Probably you will see critical regions in the right side, but it normally is compensated. But in social cognition, it has not. I think it's deserves more and more attention. And we do the same for the subcortical tract. So it's different just in the how we perform the social cognition mapping to be really not lateralized to the right, all the higher order functions. And really the final point, I think it's the most important one, is trying to categorize it to be performed for other teams. Like, how can I do this? Okay, first stage, okay, I have this large scale network, this other one, then the non-serial multitasking, and then looking for the stop point. So it's not really a different technique. It's just including some new concepts according to the recent findings.
Okay, thanks. So you're basically trying to have a more systematic approach that can be replicated also by other groups, and also focusing and expanding more on the social cognition assessment. From a practical standpoint, in terms of stimulation, you do the same 60 hertz at 3-4 seconds as you do for language or for anything else. I mean, there is no need to have different paradigm if you're testing networks, which are, of course, very complex. So when you're dealing with emotions, of course, there are not the processing of the information through the network may take several time. And so we need long enough stimulus to interfere with that. It works well with the standard paradigm, or you need to adjust your neurophysiological parameters to do this?
For me, it's really complex to answer this question, especially to answer you, Professor Sala, because you know really well how complex this this point is. Absolutely crucial. We don't know. We think and we see clearly that when we simulate some point, you can have, for example, yesterday we operated 2 cases, and we had in some points in the temporal parietal junction hyper-emotivity and crying crisis. Then when you simulate again, we didn't have the same response. After a time, when I simulate again, I had again the response. So absolutely, the information in cognition is really, we don't know exactly how it's flowing the information. To be honest, I think that we need in the next years to probably we will need to change the you know, for me it's difficult to understand how we are mapping with the same conditions language and motor functioning and cognition. So I think we are losing some information, to be honest. So we are trying we are creating a system to measure the information during the cognitive mapping, because I think that maybe what we are doing is not enough. The problem is we need really to know better how the information flows in higher order cognition. But honestly, I think that in a few years we will change the paradigm of simulation. I think so.
That's an interesting concept. No, I mean, I agree with you. We have probably been oversimplifying the way we stimulate the brain. We basically use only two ways, right? The short train for a motor, the pain field for everything else. Lorenzo Bello has proposed a more sophisticated approach, particularly for the motor task. But in general, as you said, we test neglect, speech arrest, and everything with the 3-4 seconds, 60 hertz bipolar, which we don't know if it's necessarily the most ideal parameter. My last question, which is a little bit provocative, but I like to do it because it's the same question I was asked some time ago from one of our colleagues, very much involved in neuro-oncology. We are trying now in Verona to investigate a little bit more what is possible to assess in terms of motor connectivity in those patients where a sleep craniotomy is not feasible. So we're looking at how the parietal and the premotor cortex is connected to the primary motor cortex, and what kind of deficit patient may have in reaching, grasping, or complex visual motor task, etc. And one of the question I was asked was, well, some of these fine motor tasks, it's nice to investigate them. It's nice to find a way to identify and prevent them intraoperatively. The question is, how relevant is this to our patients? And on one hand, we grow up, particularly my generation, with the idea the patient is moving and speaking, and that was was enough. And nobody cared if the patient was really returning to his social life, to his work, to his now, of course, particularly following Hugh work, we have been investigating all possible aspects of brain function, try to prevent deficits. But then we need to be pragmatical, I think, and we need to have something which is valuable to the patients and kind of feasible for most neurosurgeons. Of course, people like Hugh Dufo, Lorenzo Bello, Mitch Berge, you and many others who have been were spending a lot of time, particularly in low-grade gliomas, all the awake surgery, the cognitive mapping, can advance the field and have a very highly sophisticated approach. But we need also to be pragmatical in a way. So what's your impression? Where is the balance between recognizing sophisticated networks and function and the importance for patient to prevent injury to this network? There is no right answer, of course. I'd just like to have your, your opinion.
Professor Sala, I have reading your work for many years. I don't have the answers for your question, but I can ask you, because I don't know, but I think, I reckon that I think the same way. The problem is when, simply when we talk about a large-scale network, for us it's a problem because we simulate one point and the network is with several spots all over the brain. So again, I don't think it's enough to stop the flow of the information that the network carries on. And the point to be the equilibrium for be pragmatic. I don't know yet. We have been in more than 20 countries. I think we need to create some protocols. The problem is you can have, for example, the limbic network, and depending on the moment you simulate, you will have a problem in emotion recognition, and then you will have a problem in another task. Again, relating to your last question is, what if we could simulate 20 seconds to perform more complex tasks? Hugh Dufo probably would say that because of the meta-networking functioning, you will have not a point where you can localize the behavior. Of course, I agree. But probably our point and our work is really looking for this question you have made is how to be pragmatic. I don't know, because when I read normally the work of Lorenzo Bello, I say like, okay, I could be only trained to understand the motor mapping the rest of my life, and wouldn't be enough. So I think we need some, for example, the World Society of Awake Brain Mapping trying to put all the years together and trying to be pragmatic, because we have glioblastomas, hemiplegic and aphasic before the surgery. And what do you do? And so we have so many limitations. So clearly, this fit better with low-grade philosophy. But I think that also in glioblastomas, we need to go further and trying to see if the question is, can we do something better for glioblastoma patients? So I have the same questions, but maybe putting together all the ideas and creating societies dedicated to this, maybe in the next generations we'll have the answer. But let's try to enjoy this, the way to understand the cognition. We are really, as you said, we are limited.
Thank you. Thank you so much. Really fantastic talk. I see there is a question from Professor Mamadaliev.
Much, Professor Sala and Professor Fernandez for this beautiful presentation and very informative. So my question is, the first question is, how do you assess the emotional cognition intraoperative? What kind of tasks do you prefer to use? And the second question is, in case of recurrent glioblastomas, when the patient has already some extent of deficits, but still has some, let's say, language functions, and the hemiparesis is not so deep as that he handicapped, but can move his limbs. Is that still an indication to map these regions? And do you prefer a mapping and awake surgery for the recurrent cases also?
For emotion mapping, it's a good question because of the complexity of social cognition. We evaluated and we developed like a new task that we saw that with this task applied during the surgery, it seems to be enough to preserve the low level of mentalizing, which is recognition emotions, and the high level, which is how you really behave recognizing emotions in your context during the social life or work life. So I recommend you to use our test. Of course, we need to validate in several languages and to see if it works, because it should be really serious because it's complex. It depends on the culture of each country. So, but we are open to work with all of you. And about the glioblastoma, I think all of us think in a similar way, and Sala also. What we do with glioblastoma is performing the same neuropsychological evaluation, and depending on how the patient is really doing and how the scores are, we say if we can perform a cognitive mapping or not. Because if you see a patient that is not able to perform motion recognition tasks, the patient is not able to do the Boston test in a good way, and the patient has a lot of attention problems, why to do it awake? So it's impossible. The patient won't be able to answer the question of the neuropsychologist. You will have so many doubts. And the problem that we have is, we have the problem that low-grade and glioblastomas are different diseases. And the second point is now we have so different kind of glioblastomas based on the new classifications of molecular types. So now we have glioblastomas that we don't expect to be glioblastomas. We operate at low grade, and finally it's a glioblastoma because it's not mutated or whatever. And then we have the classical glioblastoma that we see. So my answer is try to have a good team of neuropsychology to evaluate all the functions. If the patient has, for example, 2 standard deviations below the normal range, probably the patient is not. It won't work the cognitive mapping. So I think we need to be pragmatic, and it's not a wait for a wait. We need to really understand how the patient is before the surgery. So we need a neuropsychologist. That's the point.
I see. Yes, thank you so much.
Thank you very much. Any questions from my co-host?
Yeah, thanks, Raja. Thanks, Prof. Martin, for very nice and very advanced lecture on connectivity of the brain. I have 3 small questions, Prof. I saw that you have shown that even a small lesion in the right parietal, 2 centimeter, we do need a large craniotomy because the whole concept is to get a positive mapping. May I know, based on your experience, is there any chance that any part of the cortex that you doesn't need to have positive mapping, where you can do safely with a small craniotomy? My second question, Professor, You have mentioned that you hardly use IGS, right? Because in awake craniotomy is not so important. I saw you map the white matter fibers in your surgery in the edematous brain. So may I know that how do you detect those fibers? You know, how do you assure that those fibers are in those locations in edematous white matter based on what? My last question, Professor, you are talking about connectum and connectivity. I think, and you've shown that most area, even left and right, there's a lot of connection to each other. And our current concept is we are simulating single point, right? And then we do unable to be, I saw there's a great result in your cases, but in most cases who are performing awake craniotomy, we do have some patient develop deficit after surgery. Do you think that is this possibility that because we're just meeting one point, there will be a backup point from another structure or another track, that is there a chance that in the future for certain function, there will be the need to have a multiple stimulating points simultaneously to be able to be very sure those deficits will not happen? Thank you, Professor.
Thank you so much. I will try to remember the first question. I don't think that I don't think that that will be. I mean, I think that all the problem of this paradox of non-locality is based on the large scale network, is based on different spots interconnected. Probably in a point that you maybe think that it's not crucial. For example, I don't know, posterior part of the middle frontal gyrus. You see in the right side, you can say, okay, I could perform a small craniotomy and resect the tumor, and the patient is well. I would say that if the patient is well, maybe you have not performed all the questionnaires of higher order functions, or maybe you are lucky because in the middle frontal gyrus, apparently a safe zone, it's critical for the dorsal frontoparietal network. So I think it's not, in our philosophy, it's not, we have no safe point and we need to check it out. About the craniotomy, of course, we perform really big craniotomies. I know we have been criticized because of this, but the point is we perform the classical positive mapping. So until I don't have the speech arrest in the ventral premotor cortex, I don't know if my input is enough to stop the information flowing. So because of that, I don't perform small craniotomies. I would like to perform, but based on what we think about that, it's not possible. And sorry, I forgot your last question.
The second question, mapping the white matter fibers.
Yes. This was one of the points that we published this 3-step awake cognitive mapping related to also Professor Sala asked me that what is different. The point is, I was 2 years in Montpellier with Professor Dufault, and the point is, I never understood where he began to simulate the white matter fibers. This is the point, because of course you will have the IFO where the IFO is. It's an anatomical structure. It's a difficult question. It's now we have more than 100 cases, and we begin to understand some things. But I would say that when we are close to the boundaries of the tumor and deep enough, I mean 1.5 centimeters, sometimes less, I begin to say, okay, in this posterior part, I will have the IFO running into the dorsolateral prefrontal cortex. Or, okay, I'm close to the pars opercularis. Okay, I'm getting close to the arcuate fascicle. I will begin to simulate if I have some critical fiber. Or, I don't know, in the temporal parietal junction, I will be in the posterior part, so close to the IFO, or if I will go more based out to the ILF. So it's so subjective, more than I would like, but it's more or less, it's like depending on the depth where the fibers begin, is when I begin to stimulate. And normally it's more than 1 centimeter. When the sulcus, when the gyrus is finishing, I begin to stimulate, because I don't know where it's going to be the exactly the critical point. So this is something to develop and to be more objectively teach it to other groups.
Yeah. My last question on a possibility of multiple stimulation points simultaneously to suppress certain function. Would that be possible? Thank you.
I would like to ask back this to Professor Sala, because I would like to know what he thinks. It really makes sense that if we are talking about large-scale networks, it really would work better to have a multifocal simulation, because you will be able to stop better transiently the flow of the information. The problem of this, and I have been thinking a lot about this. The problem is, if you put, instead of a bipolar simulation, you put, for example, 5 points to stimulate the brain. The point is, where do you put the flag to say that this is the boundary? So if you have 5 points, you will have a better mapping of the functioning of complex function. But where do you have the boundary if you have like all of this? Which point is the one I have to respect? Do you get me?
Yeah, because you cannot identify the location of the track involved,
Yes.
right?
Yes. So it's like, now I assume that I'm not being as enough, as precise as I would like. But with the multifocal simulation, is where is the boundary?
Yeah.
So in neurosurgery, yeah, go ahead.
Yeah, because we do have cases that we are very happy with our mapping, with our surgery, but after that patient develop deficit, and would there be a concept that there's a backup network that during simulation you couldn't detect, but when you remove more than 1 point that you think that is safe, that causing the deficit, that is the actual reason why I'm thinking that multi-stimulation may be able to tell you that which are the backup network within the same function that we need to preserve, rather than just single simulation. Just a theoretical question. Thank you.
No, it's I'm the same. I'm thinking in the same way. I think we need the most important point again is you need to measure preoperatively the same way, the same thing that you are measuring postoperatively, and to be sure that you wait 6 months to get by itself recover the functioning. But again, the point is, of course, you will be more precise with a multifocal simulation, and I think in the future we will develop something new for cognitive mapping. It's not enough. The point is where I put the boundary, because finally, as a neurosurgeon, you need to remove the tumor. So this is a problem that all of us have. I don't know. We will try with our team, and also wait for Bello, for Sarah's team, and to wait how in our minds came suddenly maybe we have a better idea to perform a safer and better cognitive mapping. I would like to have the answer for your questions. I'm trying.
Thank you. Thank you for a very wonderful lecture. Thank you.
Thanks much.
Thank you. It was a very exciting discussion. Obviously, the topic is very interesting. I think we've probably exhausted our time. Just to close up, the problem with multifocal stimulation is that you need also multi-recordings. And if you stimulate in different points, you don't know exactly what you are recording from where. So I see this quite complicated. I must say that in the last 20 years, we didn't advance much in terms of cortical and subcortical brain mapping, because again, we are using the same technique. But I do see some new stuff now coming out with the cortico-cortical evoked potential, for example, for the arcuate fasciculus, the axonocortical stimulation that our French colleagues and friends are developing. We are investigating some of these conditioning stimulus paradigm to modulate the output from the primary cortex, motor cortex, stimulating parietal or frontal. So there is some new stuff. It will take a few years, certainly, to kind of classify and a standard approach to this, but a lot of excitement for the future. So thank you again, Jesus, for your great work. Thank you everyone for the discussion. And then I give it back to the chair for our second part of the webinar. Thank you.
Thank you. Thank you very
Thank you so
much.
much.
Thank you,
Thank you so much.
Professor Martin and Professor Salah Liu. It was an exciting discussion. So I would like to mention that this has been broadcasted on WeChat, YouTube and Zoom. Thanks to Professor Shubin. And as of now, we have around 370 people who have logged in through different channels. It's time for the second session, and I'll hand this podium over to our very esteemed Professor George Willingham to go ahead with the second session.
Thank you very much, Professor Raja. And after that very fascinating talk on connectomics and expanding paradigms of awake craniotomy by Dr. Jesus, let's now move over to another aspect of connectomics, that is stereo EEG. And stereo EEG actually talks about networks, and this is actually a continuation of the same concept. And a brief introduction for those who are naive to this concept of stereo EEG. It's known that about 5 to 10% of drug-resistant epilepsy patients would require some form of invasive EEG. And since time immemorial, we've been doing subdural grids and strip electrodes. But now invasive EEG has taken a giant leap with the introduction of stereo EEG. And stereo EEG, though the concept has been there with us since the late 50s, developed by Bunkord and Talarak, it has now progressed by leaps and bounds in the current era over the last 10 to 15 years. And the robotic stereo EEG is the latest new kid on the block. And who better to tell us about it than Professor Zhao, who is a world-renowned expert in stereo EEG. So we are looking forward to learn a lot about the newer advances in robotic stereo EEG. My proud privilege and pleasure to welcome Professor Zhao from Shanghai to speak to us about the stereo EEG and its evolving.
Thanks, Chairman and colleagues. I'm Ray Zhao from Shanghai Children's Hospital. I'm a neurosurgeon specialized in epilepsy surgery. Today, my topic is robot-assisted stereo SEEG in children experiencing technical nodes. SEEG is an anatomical electrical clinical based approach that utilizes stereotactic method to three-dimensional implant depth electrodes for recording the origin and the propagation patterns of epileptic discharges. It enables spatial and temporal location and evaluation the epileptogenic zone and helps elucidate the cerebral age propagation networks. It's an invasive evaluation procedure. In certain cases, it can be served as the basis for therapeutic intervention such as SEEG-guided radio frequency thermocoagulation. And children represent a special population, and experience with SEEG, particularly in young children, remains relatively limited. The advantage and the limitation of the SEEG in children. SEEG is minimal invasive, avoiding bone flap craniotomy. Stereotactic sampling allows for bilateral implantation. It can cover both deep and cortical structures, including sulci and gyri, with particular suitability for the insular. SEEG enables guided radio frequency thermocoagulations. SEEG demonstrates a markedly lower complication rate than subdural grade monitoring. CS occurs in only one case of 277 SEEG cases versus 11% with subdural electrodes. Intracranial hemorrhage rates were about 2% versus 10%, and no infection were reported across the 9 SEEG studies compared to 10% in the subdural groups. This data collectively indicates that SEEG is the safer invasive monitoring modality. But SEEG has its limitation, such as sample bias and the difficulty to precisely localize the functional areas, in particular language areas. In pediatric populations, several unique challenges complicate the application of SEEG. Children often exhibit poor compliance with preoperative evaluations and postoperative monitoring, frequently requiring sedation or general anesthesia. The pediatric score is thinner and weaker, which may compromise screw fixation and increase the risk of electrode dislodgement during implantation or subsequent monitoring. As with any invasive intracranial procedures, SEEG also carries inherent risks of hemorrhage and infection, which, though relatively low in incidence, require particular attention in children. Clinically, auras are often subtle or absent, and seizure semiology tends to be atypical and poorly localizing compared to adults, which significantly influence the formulation of the hypothesis and design the electrode implantation strategy. Moreover, pediatric EEG patterns are prone to rapid generalization, and certain seizure types such as epileptic spasm and atypical absence are uniquely observed in this age group. In infants and toddlers, incomplete myelination further impairs gray-white matter contrast on MRI, of obscuring the lesion boundaries and reducing the accuracy of neuroimaging. Collectively, doing SEEG in children requires specialized expertise and protocols tailored to each group. We designed a retrospective study in our center from July 2018 to June 2022. A total of 99 pediatric SEEG procedures were completed. Among these, 28 cases were aged younger than 3 years, 27 cases were aged 3 to 6 years, and 44 cases were aged more than 6 years. The youngest patients were 8 months old, and the oldest was 17 years old. The body weight ranged from a minimum of 7.5 kilogram to a maximum of 77.8 kilogram. The minimum skull thickness at the entry point ranged from 1.6 millimeter to 10.4 millimeter. The preoperative neuroimaging studies include phase 1 evaluation and phase 2 evaluation. In phase 1 evaluation, 3 total brain MR scanning, including 3-dimensional T1 weighted imaging, T2 weighted imaging, and axial, coronal, and sagittal flare sequence based on ACPC lines, thin-sliced PET-CT or PET-MR scanning. Phase 2 evaluation, pre- and post-contrast axial T1 thin-slice scanning. Slice thickness is 1 millimeter with double dose contrast for direct vascular visualization image processing software. Amira was used for data subtraction to extract 3D vascular information. Fat surprised the coronal T2 flare was performed, and the software BrainShield was used for the automated cortical surface extraction. Multimodal imaging fusion and electrode implantation planning was carried out using Sinoplane software system. Next, our job is fusion of the MR imaging with PET data and construction a 3-dimensional visualization model of the cerebral cortex that incorporates vascular structures. On the day of surgery, bone markers was installed. A local anesthesia was used for the patients who could cooperate. General anesthesia, laryngeal mask, intravenous anesthesia, and local infiltration anesthesia were predominantly used for children under 6 years of age who were unable to cooperate. CT location performed in awake patients are under laryngeal mask and intravenous anesthesia. Lexel frame or Mayfield frame was applied. Registration and surgical procedure were then carried out. The surgery planning and the procedure used a Chinese operating system, Stanovision. And the operating procedure include trajectory planning, registration, and robot guidance and implantation and post-operative reconstructions. As expected, age at onset, epilepsy duration, weight, and age at SEEG all increased progressively across the groups with significant differences. Seizure frequency, however, showed no significant difference between the groups. Notably, the mean skull thickness also increased with age from 3 mm in the youngest group to 4.78 mm in the oldest. This picture shows the determination of the entry point error and the target point error. The blue dot represents the center of the actual electrode entry point, while the red dot represents the planned electrode entry point. And the blue dot represents the center of the actual electrode target point, and the red dot represents the planned electrode target point. The dotted white line indicates the planned electrode tract. With regard to the entry point error and the target point error, no difference was found in the three groups. Overall, the complication rates were low at 6%, with no significant difference among the three age groups. A symptomatic hemorrhage occurred in 3 cases, electrode pull out in 1, and infection in 1 case. In one case, this infection is not the central nervous system infection, just the skin infection. The remaining 93 patients had no complications. This finding such that SEEG is a relatively safe procedures across all pediatric age groups. Overall, 76 patients achieved the angle class 1, indicating excellent seizure control. The remaining patients were distributed across angle 2, 3%, angle 3, 9%, and angle 4, 11%. Although the youngest group and the 3 to 6 years group showed slightly higher angle 1 rate compared to the oldest group, this differences was not statistically significant. This suggests that favorable seizure outcome can be achieved with SEEG-guided surgery across all pediatric age groups. The similar outcomes were found using ILA score system. This paper was published in Neurosurgery in 2024. Our data have shown that SEEG can be done safely even in a young population of patients if we can be assured of the safety profile of this technology. Further invention can be developed to improve outcomes. This is a 5-year-old right-handed boy developed seizure with a startle component triggered by unexpected noise for 2 years. During his ictal episodes, he grimaced with sudden head flexation, atonic and axial posture. Similar seizures also occurring without startle. Cerebral MR findings were normal. PET MR fusion image shows hypometabolism in the right medial frontal lobe, supplementary remote area, and the periventral lobule. Ictal SEEG showed the seizure onset from T1 to 3 right paracentral lobule and F1 right in the right SMA. Most obvious CEG evaluation was recorded by T and rapidly transmitted to S and the electrode S and L. The pathological diagnosis indicate focal cortical dysplasia 2A, and dysmorphic neuron here were shown. This is another patient. We can see the singular gyrus malformation between the two hemispheres with hypometabolism. We recorded the seizure onset, and IFTC was performed. In this patient, he is seizure-free so far. This patient is very young. It's only 1.5 years old. This is another patient, 8-month-old girl. Hypothalamic hematoma Here we can see a lesion in the hypothalamus. We designed 3 electrodes to cover the hematoma. Then radio frequency thermocoagulation was performed. The SEEG guided bipolar coagulations were performed between the 2 contiguous contacts of the same electrodes or between 2 adjacent contacts of different electrodes. This is a post-operative MR. We can see the lesion is damaged by the electrode. The advantage of robot-assisted SEEG in children, first, unrestricted implantation, whereas the Lexel frame has limited accessibility in certain angles. Avoid the discomfort of pediatric patients wearing the frame during CT localization scanning. Pain and discomfort caused by frame installation, particularly in young children. SEEG also robot-assisted SEEG also streamlines the workflow, reducing the chance of errors. It's time-saving and efficient with comparable or even superior accuracy. In other years, we use the frame to implant the electrodes. It's time-consuming and sometimes limited by certain angles. Now we use the robot-assisted SEEG. It's time-saving and efficient. How to prevent and management of the intraoperative hemorrhage? First, ensure an adequate safety margin with about 2 millimeter safe space around the trajectory. The bleeding risk in descending order, entry point, trajectory, then target. Superficial vessels, dura mater, at last deep vessels. Management when hemorrhage occurs, irrigate with cold saline until the cerebrospinal fluid becomes clear. Sometimes severe hemorrhage occurs. The irrigation may fill the incision of the skin about 1 to 1.5 centimeters at the entry point. Enlarge the burr hole using a drill and coagulate the vessels using bipolar and visualization. Complacency or wishful thinking must be avoided. We can, in this patient, we designed electrode from lateral frontal to mesial. Here we can see the working space is relatively narrow. Unfortunately, severe hemorrhage occurred in this patient. Then we drill a burr hole, a small burr hole, and coagulate the vessels. At last, we designed another trajectory to cover this target. This patient recovered uneventful. Here we can see this is the burr hole, and we coagulated the vessels using a small burr hole, and at last we designed a new trajectory to cover the target. How to prevention and management the electrode migration. Under normal circumstances, electrode implantation is as shown in the left figure. However, in some cases, the score may be excessive thick as illustrated in the right figure when the burr hole drilling is incompleted. After screw placement, the tip fails to pass entirely through the channel, resulting in bone obstruction and subsequently deviation of the electrode trajectory. Excessive thin score or insufficient bone stress may lead to loosening or migration of the screw of the under the electrode. This is the perfect implantation, but if the bone is very thin, the migration may be occurred in such kind of patients. The minimal acceptable skull bone thickness to perform SEEG is 2 millimeter. The electrode trajectory should be at perpendicular as possible to the tangential direction of the skull to avoid the excessive angulation. This is a perfect implantation, but angular deviation occurred in this case. Different drill types may also influence the implantation. Flat-tipped drills are less prone to slipping on the surface of the skull. Pre-drill procedure could significantly reduce deviation in the electrode angle. Typically, the skin and the skull was drilled with a regular drill. A pre-drill procedure involving a thick flat-tip drill was used to grind a platform onto the skull to avoid trajectory deviation for electrode with a planned angle less than 60 degrees with respect to the skull surface. The basic principle of SEEG: first, the patient must be clearly diagnosed with focal epilepsy, and a reasonable working hypothesis regarding the epileptic onset and propagation network must have been formulated through non-invasive evaluation. The second, there is contradictory localizing information among seizure semiology, EEG patterns, and anatomical structures such as the epileptogenic zone cannot be accurately localized. The epileptogenic zone involved the critical eloquent cortex functional mapping to accurately define the surgical resection margin, thereby avoiding or minimizing neurological deficit. At last, the epileptogenic zone is confined and deeply located, and electrode implantation is intended for subsequent radiofrequency thermocoagulation therapy. The above criteria requires that condition 1 must be met, along with at least one of conditions 2, 3, or 4. Fishing net style electrode implantation without a reasonable working hypothesis must be avoided. The basic principle to be followed in electrode implantation design: the first, place electrodes in the presumed onset and early propagation zone. The second, consider alternative origins. Place electrodes in other suspected regions as appropriate. The third, delineate boundaries. Implant around the suspected epileptogenic zone to enable minimal resection. The fourth, assess relationship with eloquent cortex. Determine resectability. At last, evaluate correlation with neuroimaging lesions. Precisely assess if present. This picture shows the electrophysiological recording and direct electrical stimulation in SEEG. First, monitoring. Record 3 to 5 haptic seizure post-implantation. The EEG analysis. Determine focal onset, localize epileptic zone, assess propagation and relation to eloquent cortex. The third, stimulation value 1 Hz and 50 Hz for provoking haptic auras and localizing the epileptogenic zone. The fourth, connected regions. Stimulation of the connected distant areas may also trigger seizures. Interpret with caution. Negative stimulation does not exclude epileptogenicity, must be correlated with interictal and ictal EEG. Regarding the surgical treatment and under SEEG guidance, first, favorable for resection when a typical ictal onset pattern is confined with no early remote propagation and no eloquent cortex involvement, a clear resection margin can be defined. Second, widespread bilateral multifocal onset. Recess the adequacy of electrode coverage. Consider supplementary electrodes or palliative treatment as appropriate. The third, unclear ictal onset. Reanalyze non-invasive data and initial EEG findings. If focal onset remains highly suspected, implant additional electrodes within and around the newly hypothesized epileptic zone. The fourth, multiple onset within the same hemisphere when typical onset arises from different regions. For example, temporal plus, orbitofrontal plus, occipital plus epilepsy consider a network origin. Complete resection of the involved network cortex may improve outcomes. For bilateral independent medial temporal onset, exercise caution in resective surgery based decisions on hippocampal pathology, laterality, memory, metabolism, and cerebral frequency radio. At last, adjacent to or involving eloquent cortex, choose between the resection and palliative procedures such as radiofrequency coagulation and laser ablation based on the direct electro stimulation mapping results. This picture discusses the SEEG guided radiofrequency. Radiofrequency thermal effect between the intracranial electrode contacts. The ablation extent relatively limited, approximately 5 to 7 millimeter in diameter. The optimization strategy include target should not be excessively large. Place adequate electrodes within the target using three-dimensional trajectory crossing ablation to increase ablation volume. Implantation planning guided by anatomical electrical clinical hypothesis with increased electrodes within the ablation target. Unrestricted electrode increase or fishing net ablation for large lesions or MR-negative epilepsy is not recommended. This is our patient. We can see a huge hypothalamic hematoma. Then we design three-dimensional electrodes to disconnect the lesion. We can see complete disconnection in this patient. And this lesion, we can see here, it's not completely ablated. We just make a disconnection. This patient is seizure-free so far. This is our publications in SEEG recent years. Summary, special consideration, SEEG in pediatric patients, especially young children, represent unique characteristics, safety and efficiency. Robot-assisted SEEG is safe and effective in children with drug-resistant epilepsy. No significant age-related difference. Complication rates and efficiency shows no significant variations across different pediatric age groups. The key technical factor, skull thickness rather than age, is the primary technical limitation for SEEG application in children. And the standards of operational protocols and rational, well-designed implantation strategies are essential for successful outcomes. And at last, I want to talk a little bit about laser ablation. Laser interstitial thermotherapy is a minimally invasive procedure that is most commonly used to treat epilepsy and brain tumors. The treatment uses heat to ablate cancer cells or brain lesion where seizure begins. The procedure uses MR guidance and takes several hours, followed by 1 or 2 nights in the hospital. Laser ablation provides the benefits of traditional open surgery with less risk and shorter recovery time. Typically, the temperature between 50 to 60 degrees for 5 minutes can cause irreversible damage. The temperature between 60 to 90 degrees immediate coagulation could cause the lesion. The frameless the stereotactic robot and the laser ablation system was designed by a Chinese company, Sinovation. We use this system to implant the electrodes and perform laser ablation. The implantation procedure includes head fixation, skull drill, dual coagulation, installing the guidance screws, and then trajectory path construction, measurement the depth, then the cooling catheter implantation, the laser fiber implantation. Then the patient transferred to the MR room. Our laser ablation and the non-intraoperative MR conditions. So MR compactor ventilator is needed. The intravenous anesthesia and monitoring outside the MR room. This is our patient. This is a 12-year-old girl with daily seizure. The MR showed blood, white, and gray matter. Here we can see a blend blood, white, and gray matter in the left frontal, and hypometabolism was detected here, maybe FCD2A. Then we designed a trajectory to cover these suckers. And after the surgery, the contrast imaging shows completely ablation achieved in this patient. This is another patient. This boy with gelastic seizure, and the MRI showed. Here. The MRI showed a small hypothalamic hematoma. Very small lesion. Then we design a trajectory to this lesion. After the surgery, the post-operative imaging showed completely ablation achieved in this patient. This patient's no seizure and no complications. This is another case. This is a tough case. The hematoma. We can see here a hematoma is very huge. We can see the huge hematoma. We designed two trajectory. First, here to ablate the upper part of the lesion, and another fiber to cover the rest part of the lesion. This is the video of the laser ablation. We can see the red is indicates the temperature about 60 to 90 degree. After the surgery, post T1 with contrast, we can see a complete ablation achieved in this patient. This patient is seizure free without any complications. This is a 9-year-old boy. The symptoms are manifested as eye deviation, the oral automatism. The MR demonstrate a heterotopia. One trajectory was designed, and in this patient, complete ablation achieved in this patient. This is another patient. Is a 16-year-old female. We can see a left temple, maybe low-grade glioma here. We performed a stereotactic biopsy followed by laser ablation. Post-operative MR showed completely ablation, and the patient was seizure-free so far. We can see complete ablation, the lesion. This is the video during the laser ablation. At last, conclusion, this study contributes to the sparse literature in this field by demonstrating the high efficiency and low morbidity of MR-guided laser ablation under non-intraoperative MR conditions as a minimally invasive method of ablation of epileptic foci in the pediatric population of the medical refractory lesion epilepsy. Okay, that's my that's my talk. Thank you very much for your attention.
Thank you.
Thank you very much, Professor Zhao. That was really very, very fascinating. And I think perhaps this is the world's largest experience on pediatric stereo EEG, especially the infants that you have done. I noticed that many of them were in the first year of their life. Really very fascinating, and thank you so much. I should also
Thank you.
thank you very specially for those surgical tips that you gave during your talk. I think some of the points that you noted about the electrode trajectory going wrong, especially when the twist drill is not big enough, the fine nuances about the twist drill tip, those things were really very fascinating. And I learned a very new fact that a minimum 2 mm of the cortical bone thickness is very necessary for stereo EEG. I never really thought about it. Thank you very much, and I'm sure.
Thank you very much, George.
Yeah. Thank you very much, and I'm sure many of our audience here are waiting to ask questions. So may I invite questions from our audience, from Professor Raja, Professor Liu, and all the others who are in the audience?
Nobody has raised their hand this time because none of them is an epilepsy specialist, I think. But you can, of course, yes, Ben, you would like to ask something?
Sorry, I'm not an epilepsy surgeon, but I want to congratulate Zhao for your excellent talks. In our center, we also have a specialized team to perform the NC. And again, we're also using the robot. But I really appreciate your experience sharing. And personally, I don't do the epilepsy, so I don't have any comments. But congratulations.
Thank you.
I would like to ask one thing is like, how many days do you maintain these electrodes? In adults, it is okay, but in children, how difficult it is, I cannot imagine. How do you maintain it?
Oh, the screw fix on the skull is it's very how to say it's safe, and it's not easy to dislocation.
No, the children, they will be very restless. They want to get this thing out of their head.
Yes.
So how do you maintain that?
How to maintain?
Do you give any sedation or something like that?
No sedation. No sedation. The patient can maybe a little pain, but it's not very uncomfortable. SEEG is minimal invasive, not as the subdural grads is need a very big bow flap. SEEG just a very small burr hole, about 1 to 2 millimeter on the skull. So it's convenient and safe and comfortable versus the subdural grad. Thank you.
Professor Zhao, may I just add a little question to what Dr. Raja asked? What is the longest that you have recorded the SEEG in children and also in an infant?
The longest monitoring about 4 weeks. 4 weeks.
4 weeks, right?
Yes.
So that's around 28 days. And in the era of subdural grids, I think the longest recorded in literature is about 42 days. So probably 4 weeks is really a very, very long time. And the next question that I wanted to ask you is that, in developing countries, especially in the African and the South Asian subcontinent, the biggest challenge for stereo EEG is the cost, because one of the electrodes in India costs something like $1,000. So sometimes we have to make do with the decision for SEEG itself. So when it is a lesional or MRI positive epilepsy, we try to do away with SEEG. And also our SEEG solutions sometimes are tempered to the costs. In other words, if what the Western countries would do it with 10 or 15 electrodes, we have to make do with say 4 or 5 electrodes at times. So what is your view on how we could temper the coverage and how we could modify it for the developing countries?
It's a good question. The cost is a big problem in both in China and in other countries, especially in developing countries. So I think for the MR negative patients, SEEG is needed. The MR positive patients maybe the surgery, the direct surgery, may be a better option for this kind of patients. So I think we should balance the cost and the treatment. So thank you very much for your question.
Thank you very much. I think it's time we can wind this up. We'd like to hear the final remarks from Professor George.
Yeah, thank you very much, Professor Raja. And I think we learned a lot from Professor Zhao's fascinating and superb talk on SEEG. The main take-home message is that pediatric population definitely is not a contraindication or a relative contraindication for SEEG, because we are expanding the frontiers. SEEG in children, if needed, if selected wisely, is definitely the phase 2 investigation of choice, and we can have very, very excellent outcomes. And most importantly, it also offers surgical solutions, therapeutic solutions in the form of RF lesioning and also LITT. So we had a very fascinating add-on at the end of Professor Zhao's talk on the evolving indications for LITT, both in oncology and in epilepsy surgery. And we understand that the future is very, very exciting with all these technological advances, both robotics as well as therapeutic advances like LITT. And once again, on behalf of both the moderators today, Professor Sala and me, I must profusely thank Professor Zhao and Professor Jesus Fernandez, and also the ACNS leadership led by Professor Raja, Professor Liu and Professor Yoko Kato, for I think this is the 433rd webinar, I think, for the fascinating work that you've been doing. And the real impact of this is not perhaps realized only today, because in the future, as these recordings go into the future, I am sure this is going to impact many more young neurosurgeons in the future who take a foray into neurosurgery, and the footprint and impact of this would be there for many, many years to come in the future. Thank you so much for everything, and have a good weekend. Thank you.
Thank you very much, Prof. George.
Thank you very much.
Wonderful words of appreciation. I believe this is all because of the wonderful people like you who dedicate their time freely for us. We are extremely grateful to every person who have come here and had the will to teach the youngsters. So we'll move on to the final concluding part. I will close this officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to thank both the speakers of today, Dr. Jesus Martin Fernandez and Dr. Zhao Rui, as well as the chairs, Professor Francisco Sala and Professor George Villanelum, for the time and support for the ACNS webinars. A very special thanks to my co-host, Dr. Libun Singh, Dr. Ben, for joining us today. I'd like to mention that this has been broadcasted on WeChat, YouTube and Zoom, and as of now we have around 370 people who have joined us through different channels. So until we all meet tomorrow online, it is bye-bye from all of us. Thank you very much for joining.